Dr. Jared Travers, freshly minted hepatologist and basic scientist. He has a very exciting topic to present today, so please welcome Dr. Travers.
Thank you so much. For the special topic for today, I decided to do artificial intelligence, AI. A quick question: can you raise your hands if you have ever used AI, even just once? Just about everyone has their hands raised. Raise your hand if you use AI like ChatGPT on a regular basis. I'll try not to call out certain people, but yeah, you know, it's everywhere. Healthcare, the healthcare systems is no different. You know, AI revolution is here. As a disclaimer, I did not use any AI to make this presentation, although I was very tempted. At the talk, there was a lot of different sessions about AI. Marina Serper from the University of Pennsylvania gave a great state-of-the-art lecture on the use of AI in liver transplantation. There are multiple sessions with different providers who are actually at institutions that have already incorporated AI into their clinical practice. It was great being able to hear about their experiences. I decided to focus more on what the people said rather than focusing on specific abstracts. One of the things that really struck me was this idea of this evolution of AI. People say that we can divide it into three different epochs. The first was when AI started around the 1950s or so. It was very logic-based, very limited on what it was able to do. Examples could follow decision-making trees. Like the IBM's computer learned how to play chess and beat world masters. But there are a lot of limitations in terms of its actual use in clinical practice with these very primitive AI models. Starting about 15 years ago, there's more of this introduction of deep learning, where it was able to predict and classify information, learn patterns based on previous examples instead of just following a strict decision tree. For instance, it's able to tell, if you show the pictures, is this a cat or a dog, how many things like that. And then lately, over the past several years, there's been more of this transition to what are called foundation models, where it builds upon the previous deep learning to be able to generate new content, otherwise known as generative AI, self-supervised learning. An example is, instead of just saying, is this a cat or a dog, ask it to explain what the difference is between a cat or a dog. People have been able to incorporate it into helping it generate text for writing, ChatGPT, things like that. And with these foundation models, there are limitations as well, such as hallucinations, which I'm sure everyone's familiar with, where it will make up content. People have used it for research papers and found out that the ChatGPT made up all the citations that it used, for instance. But I think the big takeaway from this is there's been this transition from AI being sort of like a co-pilot, being able to help with certain limited tasks, to now being more of an autopilot, where people, if they want to, be able to use it to automate a lot of aspects, the aspects of a specific job. One of the aspects that I think is very important about the AI with these generative AI models is the fact that there are these multiple hidden layers. So you have your input, and then there's this big black box where the AI does something and it does your output. So you give it this data, and then it's able to come with a diagnosis, but you're not really sure what happened in between, and you can run into issues. There's a famous example of a study where they used chest x-rays with a machine learning algorithm. It could 100% accurately identify patients with COVID, but when they moved it to a different hospital, it didn't work at all. And it turns out at that one hospital, all the COVID patients had a specific gown, so that was visible in the chest x-ray, so that AI was just learning that, the patients with this gown have COVID and the other ones don't. So when it went to a different hospital where all the patients had the same gown, the algorithm didn't really work. So hopefully we move past those sorts of issues. The schematic here on the right is just talking about more multi-modal AI, meaning there's this movement towards having a lot of different inputs. Previous AI focused mostly on structured data, which is like patient lab values, things like that, things that are nice to put in a quick box. Now there's more of a focus on what's called unstructured data, so like imaging, chat transcript between a patient and a provider, things like that. to try to be able to then go through those multiple hidden layers to come out with the outputs. In the future, there's a hope that they'll be able to combine large amounts of both unstructured and structured data, so like omics data, biomarkers, microbiome data, imaging, wearable biosensors, ambient sensors, things like that, to then be able to have better precision health, surveillance, digital clinical trials, virtual health coaches, things like that. In terms of how AI is being introduced for an individual clinician, there are 6 different areas that I really noticed where people mentioned. The first were in patient portal messages, or MyChart messages. It's well known that the amount of patient messages that providers have to answer has gone up dramatically since the COVID pandemic started. So there have actually been 3 institutions that have incorporated AI into their EMR, where it will auto-generate a reply to a patient message, and then the provider will actually look it over and decide whether they want to edit it or they can just submit it as is to the patient. I believe it was UCSF, UCSD, and the University of North Carolina were the 3 institutions that brought that out. And then there was a speaker from UNC who mentioned that he really likes how that feature worked, although there was an issue that was brought up, is that at this point, it usually takes longer to read the message than it would be just to type it themselves, just because they don't really trust it. But I think with more accuracy, that could be a good time saver. There was a study from Duke where they actually used that in a certain subset of patients, and then they asked the patients which responses they preferred. It turns out they actually preferred the responses that were AI generated over the ones from the providers. Even though the ones from the AI were longer, they were felt to be more empathetic, which I thought was very surprising. A second aspect is clinical documentation. There have been multiple, UCSF, they've introduced this thing called AI Inpatient Insights, where essentially in the chart, when you open up an inpatient encounter with a new patient, it will summarize all their previous encounters. So if they came in with acute liver failure a couple of years ago and had a liver biopsy, it ideally will show that, and then there'll be a link where you can click it to see what the liver biopsy shows. Still kind of early days with that sort of technology, but that could be very groundbreaking. It takes forever, especially if you have patients with very long charts who've had multiple admissions. If you could use AI to summarize the chart to be able to quickly identify the pertinent information, that would be really cool. There are another example that was brought up was there's a study where they used AI versus internal medicine residents to write discharge summaries for hospitalized patients, and they compared them. And it turns out the AI ones were felt to be more cohesive and more concise. But then there were issues, the AI one had more confabulations where it was making up data. So it felt like the internal medicine resident ones were still preferable at this point. But again, that's something that hopefully we will be able to improve in the future. Additionally, I'm sure people have heard about these ambient AI scribes. Has anyone ever used one of them? Yeah, a couple of hands. Yeah, there's a lot of talk about them. It seems like they work really well. I'd be interested to hear about your guys' experience later. There was one study that looked and showed that patients actually prefer the use of the ambient scribe, because the doctor, instead of writing on their notes or looking on the computer the whole time, they're able to just talk with the patient knowing that a transcript is being made, and that it just pre-populates a note and they're able to edit it as needed. In terms of score calculators, Stanford and the Children's Hospital of Philadelphia have enacted this feature called Chat with the Chart, where you can actually type in, can you calculate a FIB-4 score for this patient, or can you trend this lab versus this lab, and it will make a graph comparing them. I think those are really great features that we'll be able to use in the future. Another thing that was brought up were the e-consults. So the UCSF, the Jin G's group there has developed a program called Versa, where instead of having you do all of the work for an e-consult, it will look at the chart, incorporate AASLD guidelines, and print out a summary of what they would recommend. So if there's a specific patient, they're coming in for acute liver failure, what should the management be? It will then incorporate all of that, and then it will then provide a summary of what they would recommend. So if there's a specific patient, they're coming in for acute liver failure, what should the management be? It will then incorporate all of that, and then it will then provide a summary of what they would recommend. So if there's a specific patient, they're coming in for acute liver failure, what should the management be? It will then incorporate all of that, have a pre-populated summary that a clinician could then use to review to determine whether or not that was appropriate and send it out from there. And the hope, they haven't actually put that into any rigorous trials at this point. It's all preliminary data just within their own institution, but they're hoping to use that in the future. And then finally, with diagnosis, there were two studies that I thought were very cool. One was from a group in Spain. They used this AI program to diagnose hidden hepatitis C infections, both retrospectively and prospectively. So the first thing that they did was they had it look through about 15 years of patients. It was able to identify patients who had a previously positive hepatitis C antibody or RNA but had been lost to follow-up. And those patients were able to get set up with a hepatologist to get treatment. The second thing that they did were all patients admitted to the emergency room between 40 and 70 was able to determine whether, by reviewing their chart, whether they should be screened for hepatitis C. It was able to identify positive patients. The last study for diagnosis, there was a study out of UCSF as well where they compared an AI versus manual extraction for looking at a large number of hepatitis C radiology images, looking patients having liver MRIs, figuring out what the LIRAS category was, tumor size, things like that. And the AI had about a 90% accuracy in terms of identifying. While it's not 100, not saying we should use it yet, the turnaround time is a lot faster. Instead of it would be a lot faster if you upload the image and AI is able to instantly tell you what the LIRAS category is instead of having to wait for the radiologist. Now, those were the main examples of things that are being in use now. There's a lot of discussion about future improvements. So this slide is showing all the different areas, for instance, where for just in one disease, MASLD AI could be incorporated. From using deep learning and natural language processing to identify patients with steatosis, to predicting response to different drugs, using AI for note analysis and more accurate billing, using AI for patient instructions, allowing more of a patient-provider interface, as well as looking for comorbidities such as cardiovascular risks. There's even one proposal, this was in a review article that came out just this year, where AI can help do a whole comprehensive MASLD care. So in the future, what they imagine is you have a patient, they're seen in clinic, they get sent with an ultrasound, get labs, things like that. If they have any questions that come up, they get a message in the portal, the AI will respond. And then also at home, there'll be like smart scales, measure their daily weight gain, so they can use that to determine if a patient is developing ascites, because there'll be a precipitous rise in their weight. You want to look at frailty or physical activity, use something like a pedometer to look at how much physical activity they're doing, using chat transcripts to covertly identify hepatic encephalopathy. And so all of this in the future, what they hope is that they will be able to improve MASLD care in a more comprehensive manner. Then the last study, which I thought this was just incredible, was they actually simulated a liver transplant selection meeting with only AI. So here they had 8,000 clinical vignettes of patients from the SRTR who received liver transplants. They had a medical scribe convert them into a clinical vignette, and then for about 15% of them, they randomly added in absolute contraindications to liver transplant. And so then what they had was they had 4 different AIs. They had an AI act as the transplant surgeon, an AI act as the pharmacist, an AI act as a social worker, and as a hepatologist. They did their thing, had a discussion, and then they had an output. As their output, they had a report summary and a decision about whether to allow this patient to get a transplant or not. And it had a 98% accuracy in identifying absolute contraindications to liver transplant, and had about a 90% accuracy in identifying patients with 6 or 12-month mortality benefit. Now, I don't think anyone is suggesting that this is going to replace liver transplant selection meetings anytime soon, but you can imagine the power of this, or even just for things like summarizing the transplant selection meetings, or you can imagine if you're not sure, how's this going to go for my patient, maybe you can do a simulated one. So you can tell a patient, no, I think you'll have a 50% chance of being approved or not, but if these sort of things happen, maybe we can improve this. Now, I did focus on positive aspects for a lot of my talk so far. I think there are also some negative aspects that need to be highlighted. You know, there's a lot of risk for disparities and bias to appear in AI, specifically ethical concerns. You know, I think there's a big issue with the hallucinations in generative AI. Another aspect that I personally would be concerned about is the malpractice issue. So say I'm seeing a patient and the AI tells me to do something, but I clinically disagree, and then there happens to be an adverse outcome. What happens from a liability perspective? Like, is there going to be someone, a malpractice lawyer, maybe from Adrian's family, you know, saying, oh, but the AI told you to do this and you disagreed, and then this bad thing happened, why didn't you listen to the AI? You know? In addition, if there's an issue with the AI, who's responsible? The manufacturer or the user? You know, with a car, if there's a car accident that happens due to a defect in the car, the manufacturer is responsible. But because AI is a black box, how are you supposed to know if there was an issue with the AI versus with the user? So I think these are issues that will need to be addressed in the future. In addition, I think there's some access issues. Like right now, AI is being instituted in these large, you know, academic powerhouses. How's it going to get introduced to the community in more rural settings? Is it going to be limited to certain EMRs? Like, is it going to be everyone with Epic has access to this AI, but if you don't have Epic, then you don't have access to it? And then anyone still using paper charts is definitely going to be left behind in the AI revolution. Yep, and then the last thing I just want to mention, Ratan Yukar at the liver meeting mentioned that the AASLD is starting an artificial intelligence special interest group. So if anyone is really interested in that, I think there should be some more information coming out in this next couple months about this very important issue.